Welcome to Berries in the Interim podcast, where we explore the cutting edge of innovative clinical trial design for the pharmaceutical and medical industries, and so much more. Let's dive in.
All right, welcome everybody back to In the Interim. Today we are going to talk about a really cool trial, by the way, I'm your host, Scott Berry, and I have a guest today, and I'll introduce the guest as I introduce the topic. The topic today is the ICECAP trial. And ICECAP is, if I put together of doing this for 25 years, sort of my 5 favorite, 3 favorite, 10 favorite, whatever, ICECAP is on there. This is a very, very cool trial. I think the trial design, the scenario, very cool. And we're going to talk about that trial design. And joining me to talk about that trial design is Will Meurer. Will is a professor of emergency medicine and professor of neurology at the University of Michigan. He's also a medical and statistical scientist here at Berry Consultants. So Will, welcome to In the Interim.
Yeah, I'm so happy to be here.
And sometimes I ask my guests, are you a Bayesian? And if you have video access to this, there are some people that have only audio access to this. I don't need to ask that question as Will is wearing a t-shirt with Bayes' theorem on it. So he is declaring his allegiances just from the start. And ICECAP is a Bayesian trial. The final analysis is Bayesian, the trial is Bayesian, but let's get to the ICECAP trial. The story of the design of this trial is as fun as the design itself. So let's talk about, we'll talk about the development of the trial, but to give people a sense, what is the ICECAP trial? What is the syndrome? What are we treating in ICECAP?
Yeah, so when we take like high school or middle school health class, we know that, if your brain stops getting oxygen, bad things happen to it. Sometimes, people are, maybe learn, oh gosh, in 3-4 minutes, your brain is going to be damaged irreversibly. So when people have problems with their heart, such that their heart suddenly stops beating, like they're having a heart attack, there's a blocked artery, or for whatever reason, the electrical information in the heart just goes haywire. All of a sudden, there's no blood flowing up to the brain. The body goes down, and hopefully, there's somebody nearby if that happens to you, so that they can start CPR and potentially get an automated external defibrillator and restart the heart as quickly as possible. When I was a medical student at the Cincinnati VA, I was just walking by the ER one night, and literally a guy went into cardiac arrest just as we were walking by, and somebody got the old school paddles, went up to the guy and zapped him, and he woke up, screamed and we got to him before he developed any brain damage. But in lots of cases, we don't get the heart restarted that quickly, and because of that loss of blood flow, the brain is damaged. And we don't know, though, at the moment that people get the heart restarted, exactly how damaged that brain is going to be. All the cells that are inside the brain, we think of neurons, there's blood vessel cells, there's connective cells there. These are all hurt by this lack of oxygen, but they're not all necessarily going to die. And the idea of treating cardiac arrest, first you have to deal with the heart. If you don't get the heart restarted, it's very hard to live. It's really sort of game over. But if you get the heart restarted, then the most common way people die is because of brain injury, so that they don't wake up. So one of the things that we know is that when the brain is injured, high temperatures like fevers can be really harmful. So that, the way I think about this is there's a bunch of these neurons and other cells inside the brain. They've been hurt. They're still functioning, but they're maybe not happy about it. They haven't decided, like, gosh, should I turn myself off? Should I go to hit the self-destruct button because the situation is bad and I'm not going to be able to recover? Or should I give this a little more time? one way of thinking of this, it's an oversimplification of biology, is that when the temperature goes up, more of those cells decide, they're done, that they can't survive this. And we see this not just in the brain injury from cardiac arrest, but we also see this after stroke, traumatic brain injury. Anytime there's a serious hit to the brain, there is, this really common situation that fever is bad. And these are sick patients in the intensive care unit. They're on mechanical ventilators. So there's plastic and, coming out of all sorts of body orifices. So that people are very prone to infection in this fragile state. So these fevers can be quite bad. So in the early 2000s, well, even before that, like way back.
So let's back up. So these are patients suffer a cardiac arrest. There are other reasons why somebody has lack of blood flow, and so the whole therapy that we're going to investigate might be interesting in there. But in this trial, we're looking at they suffer cardiac arrest. For some period of time, there wasn't blood flow. It gets restored. So these are patients that have been restored. They come into the emergency room where Dr. Meurer is in that. And then the question is, what do you do? Do we have therapies for them? Is that right? Did I get that right?
Yeah, no, that's right. And,
okay.
And this is like this is damage to the whole brain. So if a lot of people are familiar with stroke and stroke research, and in stroke, you have damage to one part of the brain that's sort of fed by one blood vessel that's blocked. And in that case, people usually are awake, and you can measure how big a stroke they have by how weak their arm is. This is part of what I do in my daily work, or at least a few times a month when I work on the stroke team. So in stroke, you can kind of quantify the severity with this, with like an NIH stroke scale exam. You do a special type of imaging test, which you've all worked on, a CT perfusion that can say, look, this is the volume of the brain that's at risk. Whereas in cardiac arrest, we don't have a real true marker of the severity. It's like the person looks comatose. They're not responding. Maybe they're looking around a little bit, but they're not able to follow commands. But we don't have a sense as to how big a hit their brain took and whether or not they can recover. So that's why we want to try to implement therapies that protect the brain or can limit the damage, because that would be what can help improve the outcomes. So that's that's sort of the stage. The patient has been resuscitated by usually the paramedics in the field. Sometimes a bystander brings like an AED, and they get the heart restarted, and then they've come to the emergency department. And unlike that guy at the Cincinnati VA who woke up screaming that his chest hurt, these folks are on a mechanical ventilator, and really not able to speak or follow commands, and that would be the coma after cardiac arrest. That is the brain injury.
Okay, and the heat you described that could accelerate neuron death, and if it considered to be a negative, that's the human body creates this response of a fever, high temperatures, and hence the therapy. What therapy are we investigating in this trial is potentially beneficial for those patients that come in to see you?
Yeah, and it can go even a little further. I mean, we've heard those stories of people who fall through ice on a lake and are under the water in the lake for a half hour. To some degree, that coldness of that lake is much colder than we did in the ICECAP trial, but that slows down all the body's circulatory processes, can slow down those cell death processes, which is why we sometimes see people who have these miraculous recoveries even after being underwater for sort of mind-boggling amounts of time. In addition, for some types of cardiac surgery where they need to stop the heart to do work on, say, the aortic arch, and to fix things, they put people on a bypass machine. But in certain cases they know that if they cool the body down quite a bit before that, they can, the fact that they have them on a bypass machine helps keep blood flowing through the brain, but there still is a chance that you could injure the brain in those types of procedures. So there are some where they will do a hypothermic treatment during these planned surgeries. We also know that in really, really little kids who've just been born, who maybe have a umbilical cord wrapped around their neck or something, and they don't get enough oxygen during the birth process, they have some brain damage. And those kids, if you cool those kids also down to about 33 degrees on a cooling blanket, you can limit the amount of damage they have and increase the chances that they live a normal life without any developmental problems. So there's these other sort of human cases where we've seen hypothermia be protective. A lot of people have done animal research that it's more mirrors this cardiac arrest situation that has shown that this is really one of the best ways to protect the brain. And part of that, we think, is because when we talk about these cells deciding to die, there's a lot of ways they can decide to die. And you could think, oh, I can get a drug that blocks one of those ways. But then the cell just goes around, basically goes around the corner and takes a different pathway to dying. Dissimilar from cancer, where it may be like, this is the specific thing, and if I block that, or a sort of monogenetic neurologic disease, where you're like, if I can stop the body from making that one bad protein, I can stop the disease here. But there's lots of ways that the brain dies. So the thought is that hypothermia maybe slows down multiple mechanisms, and that's borne out in the animal data. But to some degree, we don't really know how to implement it in people. Like, who are the people we should cool? You don't want to cool people who aren't very injured, because then you're exposing them to more time in the ICU and on sedatives and all this stuff. But then on the other hand, you don't want to, if you can protect somebody, you want to cool them long enough so that you're giving that brain a chance to get as much recovery as it can. So they did some studies back in 2000 that were relatively small studies called the HACA study and the Bernard study, but they did have pretty eye-popping results of improving mortality. They didn't use modern devices. They more or less used ice packs and cooling blankets, fans, things like that. But they also, in their control groups, didn't do much to control fever. So that was one of the criticisms of those studies, in that was the effect they saw from hypothermia more this protection from being low, or was it the fact that being a little low was a good way to not go high? So that left, even though the guidelines that came to be after 2002, when those studies came out, were favorable and saying that we should cool people for roughly 12 to 24 hours, there were these unanswered questions as to, would this really work in a bigger population, and also a population where the ICU was more diligently treating fever in a control group.
Yeah. Okay, so walking into the design of this trial and the design process of this trial was extended, getting funding and various things. It's thought that hypothermic cooling of patients that come in after cardiac arrest, restoration of the heart, of blood flow, they come in, does cooling them. It's thought that cooling is beneficial. There still remains a number of questions. Conclusive evidence of benefit is also not there. So going into this trial, it is somewhat standard of care at your University of Michigan hospital that if somebody suffers from this, they will be cooled. So what is it that ICECAP decides to explore? I imagine it could be temperature. I could imagine how fast you get them there, whether you cool them at all, whether you just prevent this, how long you cool them. What is it that ICECAP is going to explore?
Yeah, I think one other thing that maybe I should point out about those early studies is, one thing that they did was they focused on sort of the patients who they thought had the best chance of recovery. And these were people they thought had a cardiac arrest from cardiac causes. And that meant when EMS shows up, they're in this ventricular fibrillation or ventricular tachycardia type rhythm, like my guy at the VA. They get shocked and their heart gets restored. So that's sort of one mechanism why the heart starts, or why the heart stops. And that's thought to be favorable because basically you're like a normal person. You don't know you have any medical problems. And all of a sudden a clot flicks off to a big vessel in your coronary and bam, you drop. So your body isn't very sick from other diseases, maybe a little bit of hypertension here and there, but getting that person back and going is one thing. The other type of cardiac arrest where somebody's heart stops is what we call non-shockable arrest, and that comes from something else going on with the patient. Like they have a bad respiratory problem and they get less and less oxygen, and all of a sudden there's not enough oxygen in their bloodstream to keep the heart moving, or they have a blood clot, or heaven forbid, and this is something that we will find came up more commonly than we thought, they take an overdose and they stop breathing. And when they stop breathing, the body is more slowly being deprived of oxygen. Whereas in that initial case of the sudden drop, you have a normal oxygen level. So even though your heart has stopped, there was a fair bit of oxygen that was and stuff that was pushed up to the brain. Whereas if you're not breathing for a while and a while and a while, there's even more sort of pre-injury. So when I said we don't really know much about severity, we did know that one thing. And the one limitation of the trials was those 2002 trials, they didn't think those people with the latter type, the non-shockable, had a lot of prospect for recovery. So they really only studied those who had shockable rhythms. So another big question we had is the guidelines were vague on the non-shockable people. They said, please cool the people who had shockable rhythms, but the people with non-shockable rhythms, we're not sure. There's no reason to think that the brain wouldn't potentially be protected from hypothermia based on these two different mechanisms. But there was a worry that maybe these people had such a bad prognosis that if you include too many people like that in your trials, you're not going to have enough good outcomes to see a difference.
Okay, so the reason for the cardiac arrest, shockable and non-shockable is a question. And then largely hypothermia. This trial, by the way, I'm not sure we laid this out. When you and I are speaking right now, this trial is over. That we know the results. We're not going to talk about the results. The results are coming out. Believe they've been accepted into JAMA, but that we're going to have another podcast of the results, and we're going to talk about the results and what they mean. We want to talk about the design, so we're setting up the design part of this. So what is it? So you are going to look at two different kinds of patients, shockable and non-shockable. What is it? What are the interventions you're assigning to a patient?
I think one of the things is, and we arrived at this after having these meetings as part of this interesting and really cool regulatory science initiative that was sponsored by the U.S. Food and Drug Administration and the U.S. NIH and the Office of the Director at the NIH. We did this project called Adapt It, which is where we started to work together. And in the process, initially the sort of straw man design for something like ICECAP was to look at a few different cooling durations, like 12, 24, and 48, in shockable rhythms only. And as we had more feedback from a variety of stakeholders who were at these meetings, it became clear that was probably too narrow. There was so much uncertainty in the non-shockable people, but a great unmet need, that we should work to try to study both of those populations at the same time. But as we emerged in terms of how we were planning the trial and what decisions we're making, we wanted to make sure that if there was a signal in the shockable rhythms, that we could sort of find that even if things were different in the non-shockable rhythms. Or similarly, because the non-shockables typically have more brain damage, maybe they need to be cooled longer. So those were some of the things that came through. We didn't want to study how cold you made them. We focused on 33 degrees or roughly 90 Fahrenheit, because from the animal models, that was sort of the best. That was a sort of sweet spot. Some people have looked at other, like 34 or 36. And we based on our read of the human and animal literature, looking at depth wasn't so interesting. Duration, we felt, was most interesting. Like I said, in the neonates, it was about 72 hours. There was a very encouraging study in pediatrics, which didn't quite achieve statistical significance, called FAPCA, but 48 hours of cooling in kids who are 18 and under most of whom were actually 2 and under. 48 hours of cooling was quite promising in terms of improving survival. So there were those sorts of numbers. But then in that one of those first Australian studies, they got people cooled really quick, and they only cooled them for 12 hours, and they also saw great results. So we had this sort of range of uncertainty. So duration was important, but another thing that was crucially important to us was the therapeutic window. And we really felt that based on the preclinical data, that it was important to get people cooled quickly. Some people come in cold. Obviously you've spent a lot of your life up in Minnesota. Easier for a patient to get cold up in Minnesota in the winter than it is in Austin in the summer. So there is some of that, but a lot of it is really, if the body's brain is injured, it actually turns off your temperature center to some degree. So your body is sort of, even in a relatively warm environment, your body is going to get cold. So getting people cold early was something we looked at as very important to reduce variability in the trial, right? Because if we're testing these different durations, but some people are getting cooled starting 12 hours after injury. Some people it's 2 hours after injury. Some people it's 6 hours after injury. We felt that heterogeneity could really sink our trial. So we did have a focus on, with the hopes that sites would get really engaged and get devices on people quickly, to have people cooled quickly as a condition of the trial. Because of that, and because the guidelines at the time it was designed were cool everyone, we couldn't have what one would consider a classic control group in terms of let's just put a device on and set it to 37 degrees, 98.6, and just make sure they don't get fever. So that we couldn't do that because we wanted people to be cooled before they were even to be eligible for the trial, so that sites were cooling everybody as a condition of being in the study, at least anybody with a coma, that had to be their usual practice to get into the study. That meant we could require patients to be cooled to a certain amount before they could be randomized to a duration.
Okay, so we are in the ICECAP trial, we're going to randomize people to a duration. And a critical part of all of this is that we can't do no duration, no cooling. You would slow down people. They're going to be cooled by trying to get consent or a waiver of consent or all of that. Standard of care is to cool them. So everybody is cooled in the trial, but you're going to vary the length of time they're cooled in the trial within this. And initially, and going back to this, by the way, the Adapted project that you mentioned was a fabulous project. I think we had 6 different trials, and the goal of that project was to explore innovative designs being brought to clinical trials in the emergency room setting, and to study barriers to bringing in innovative design. And interestingly, I think the number one barrier was statisticians, but that's a topic for a different day. And there was research, and we had IRB approval to study the people building the designs as to what were barriers and what were going on. So I remember the initial design that I simulated for this trial was randomizing patients to 12 hours, 24 hours, and 48 hours. And initially, it wasn't the 2 populations, so we'll kind of ignore that part. And we had a dichotomous outcome of their 90-day MRS status, and we simulated those trials and showed a number of those results. And a lot of times, it didn't really answer the questions. There was a great deal of, wow, boy, I wish we had more on the smaller ones in this case, is even somewhat of an optimal curve that it kind of goes up at 24 and kind of comes down. Left huge uncertainty whether this was flat, what the shape of this curve was. So there was a desire to have more durations, focusing patients where the best benefit was being seen. And so, as you described, the next generation of this trial was, first of all, changing the endpoint to analyzing the whole scale, and we'll get to how we did that. But we opened up 6 hours, 12 hours, 18 hours, 24 hours, all the way up, I think, originally to 84 and 96 hours. There were 12 different durations that a patient could be randomized in version number 2 of this trial that we started to simulate.
And then I think this was one of the really great things about the adaptive project was that by sort of illustrating a simpler design first, you could show people like, oh, I don't know, at the end of that trial, I'm going to be sad or have this anticipated regret as we talk about it, or doing the pre-mortem, right? If we do that 12, 24, 48 trial and it's sort of like, oh, we should have gone out to 72, or oh, maybe 6 would have been better, or so that, I think that's an important concept. I think the thing that also is, I think really fascinating is that, by seeing the way the trial could come out, then you get people together and they're like, gosh, we need to do something a little different. And the other thing though is you do have to put this, and sometimes I think, again, and when you say like statisticians are the barrier, you're also working with, hey, the guidelines say cool everybody for 24 hours. So to some degree, you could say, yeah, let's look from 96 to 0. From a statistical perspective, the most efficient way to do that is you're going to start putting people on both ends to sort of see like, oh, is this possibly flat, or maybe there's going to be an upslope in the middle, but kind of go into the ends and fill in. But since those are far from, both those are far from what was guideline recommended at the time, the human constraint on the model was like, we do have to do it this way because it's not ethical to all of a sudden cool people for 96 hours. People who are in ICUs, you're going to, if they start to wake up, you're going to want them to let them wake up. So that, if it's only 6 hours of cooling, gosh, the guidelines say 24. Patients are going to be like, why are you putting my family member in such a small duration? So we did have this constraint because there was, real recommendations for practice that we, I think in retrospect, sometimes people say, well, like, why didn't you just evenly distribute them across 10 arms? And it's like, it wasn't, based on what we knew about the science at the time we were coming up with the design and starting the trial, that wouldn't have been ethical. So that's, I think, important. And I think that was one of the things, you would show us a set of simulations and we'd be like, ooh, it's looking a little too long on this neutral case. Like, why is it putting people over there? And then you'd say, well, because it wants to know, and that's how it's going to find that slip of that line, and say, well, like, let's see if we can nudge that backwards so that it needs to have stronger evidence that there's an upslope between durations that we've used before, 12 to 48, before it starts looking at those longer durations. So I think that was so crucially important. It took a lot of time and energy to go back and think of those things, but it's one of those things though. When people look back at the design, sometimes they're like, hey, why did they do that? But once you know the results, like, the reason we were doing the trial was we didn't know the results. We didn't know what this was going to look like. So we wanted it to be flexible to a variety of different truths and be able to get us an answer that could be very useful to us under a variety of these scenarios, whether it was like upsloping late, upsloping early, flat, going down. And I think that was something that when people say, well, why'd you do all this complicated stuff? This is something that's come up in adaptive designs. I think like the Aston trial of the neutrophil inhibitor for stroke, I think is sometimes cited. It was a really innovative design. They went through so many different dose tiers in their design, and I thought it was like an amazing trial. But then critics later are like, oh, they could have learned that with 3 doses and a third of the patients. But they didn't know that in advance, right? Like if they had done 3 doses, maybe they would have tested 3 different ones after that initial trial, as opposed to they got to a very convincing answer that in the population they were testing, their agent, didn't help those stroke patients. So I think sometimes when we have adaptive designs that kind of go more into that neutral space, people are like, or even adaptive designs that show something positive, people are like, oh, well, it would have been much easier to just assign them to those 2 groups, right? But it's like, we didn't know that when we started.
Right. Right. Okay. So through the simulation, and as you described this quickly, by the way, 84 and 96 hours dropped out largely for operational things that people are for 5 days in the emergency room. And it would have been awkward to do the trial where they go to the ICU. So we dropped those off. And I remember showing a simulation where initially we simulate to those same three arms, 12, 24, and 48. And then we do response adaptive randomization. We allocate patients where they're most likely to be benefit across that curve. If the low doses are doing the best, we put more there, refining that later ones. And I showed an example, a single trial where the curve went up, it was flat, it went down a little bit, but then it started to go back up. I was using a smoothing spline across the 12 durations. And it started to assign patients at 72 hours. And the clinicians all said, nope, we would never do that. That dose response curve is not believable. It's not conceivable that the curve across durations would start to decline, that patients do worse as you cool them more. And all of a sudden it starts to go up again. And that was a really important insight. Also, on the other side, largely it was that this curve is going to be an inverted U. That if this is beneficial, or if it's not beneficial, it fits on this curve, that there's going to be a point where cooling more is beneficial. It may then be flat for some length of time, and then it's going to go down. And we know at the extremes, those would be the cases. If you cool somebody for 30 days, they're not going to do well. And we know that it's going to get worse. Now, so that became the analysis model of this trial, that it's an inverted U dose response that can have a flat area. The important part is all of the 10 doses could be on the upslope. So we modeled it so the doses are somewhere on that inverted U. They could all be on the upslope and 72 hours is the best. They could all be on the downslope and cooling is bad. The more you cool them, the worse they get. They could all be flat, that from 6 to 72, it doesn't matter, it's flat. Or it could go up and be flat. It could be flat and go down. That's the model that drives the trial. And what's really nice about that, so there's a Bayesian model of this inverted U that allows the doses to be ordered somewhere on that scale. And what we're looking for is the smallest dose that achieves the highest level. And that's defined by as this optimal dose. It's defined by the curve. Because we know if it's getting flat, you don't want to go bigger. There's no reason to go bigger. It's not going to go flat and then up. It can't in the shape. So we use that in response adaptive randomization to allocate patients. And that was the next version of this. And we added in, you addressed these guardrails that we didn't want to start with people on 6 hours. And we didn't want to start with people on 60 hours or 72 hours. If the evidence was building that the dose response was continually increasing through up to 60, and the algorithm thought it was likely that was the best, we would open that arm with guardrails. And we would open 6 with guardrails if it appeared that 6 might be the most effective dose or this optimal dose. Like if it looks really flat, we could open 6, only with adaptive conditions in the trial, is how we started to migrate the design.
Yeah.
Go ahead.
You keep going.
I was going to say, then it became, we want to investigate both non-shockable and shockable. And the concern is that this optimal place is different for shockable and non-shockable. As you set up, it might be, depending on the etiology for why the person went down, you might want to cool longer or shorter within that. So we ended up moving the design to having the same duration response model modeled separately in the two populations and having different response adaptive randomization probabilities by rhythm type.
Yeah, the thing I was going to say is, that's another thing, right? People, would say, we don't think this duration response can go up and down, but somebody later might like do some animal research and say, oh gosh, biologically, you need to cool during this reperfusion period, and then maybe you need to cool later during this, period where the brain is getting swollen. But again, that's not one of the arms we had, where it's like cool from 6 to 12, pause, and then if you haven't woken up, cool again from 72 to 96. One of the things that I sort of brought up, I think, back when we were having these planning meetings is, gosh, wouldn't it be nice if there was some way that we could tailor the treatment? This is this sort of Goldilocks approach to cooling. Like if we had some way to measure the brain and oh gosh, it's crying out to us as we rewarm somebody. Let's then make them cool longer. And again, that was a lovely idea, but we as the scientific community at the time said, hey, Will, that's cute, but we don't know enough about how this works to do something that complicated that might take 1 billion patients. But we have earnest uncertainty in these durations that we're testing, and whether there's, I think, as we'll get to next, while we don't have a control group, if everything's on the upslope and it's a pretty good upslope, it's a pretty good way to connect the dots with a no cooling group. So I think we did have to make, we did think that there could be individual designs that maybe could be better for patients, but we didn't have any of them off the shelf, and we didn't have a good way to sort of think about how we could implement something like that sort of, let me cool them until their brain tells me it's ready to wake up.
We're ready. Yeah.
But then one of the other constraints that we all have in this space that is also something that's sort of really interesting is there is a lot of pressure in the US healthcare system in particular to kind of get bored with providing critical care to somebody who might not wake up and say, yeah, Uncle Joe's lived a good life, but not sure if he's going to wake up. And then having people want to do care limitations and remove people from technological support early, which commonly happens. But in a trial like ICECAP, that's a huge problem, right? Because these people aren't being given an opportunity to wake up. One of the potential mechanisms, I talked about biological mechanisms of cooling. One of the potential mechanisms of cooling, at least in the clinical trials sense of potentially improving outcomes, is the longer you cool, you can't pull the plug on somebody while they're cold. You have to, so if you have a longer time period, you're basically, sort of creating this sort of reverse shot clock of, you got to wait at least this long before you take a shot at letting this person wake up. And in some of the trials that have been done, people have been waking up, 22 to 30 days after the injury. Now, that's not to say that every single patient who has a cardiac arrest should be given 22 to 30 days to wake up, but many of them aren't being given more than 2. And that's, again, in certain European countries, people are much more willing to give it a week or 2. Again, I'm not trying to make this a sort of value judgment on different societies, but it's an observation that people do handle these things a little differently in places. And there's also a lot of clinicians who are like, I'm sure they won't wake up. But if you tell that to everybody at day 2, and sometimes it takes people 5 to 20 days to wake up, you're going to be right. None of your patients wake up, but some of them would have if you had given them longer. So we also have this sort of, social element of the trial and working to do, another intervention. You say, well, why did you pick duration? Because that was most interesting. We tried to limit variability on this care limitation by having clinical standardization say, please talk to us if you're doing this. You have to have a defined protocol to prognosticate where you're doing an EEG, you're doing brain imaging, you're doing blood tests, to make sure that if you want to tell a family that this person isn't going to wake up, you do have some additional evidence that sort of backs that up, that it's pretty unlikely that they're going to wake up. So that was another aspect of the trial. It was a feature of some concurrent European trials that went on, that they did that in a standardized way. So that's another thing. But from a study design perspective, when people don't complete their duration of cooling because of early care limitations, it introduces noise into our trial. Our trial has less ability to pick up a treatment effect when those observations aren't contributing really to the treatment effect estimate.
And we for especially the statisticians out there, we do intent to treat. So if a patient is assigned 48 hours and dies at 12 hours, they're in the 48-hour arm, and their outcome is that. If they somehow come off of it at 24 hours, they're 48 hours. So it's intent to treat from the arms of that. I think it's in a really important part in the interactions of this. I remember we went to the NIH presenting to get this funded. I think there was discussion about, at that time, we went with members of the FDA. The FDA really wanted this trial to run. Bram Zuckerman in particular really wanted this trial to run. Now, medical devices out there have been approved that they cool a patient. That's not tied to clinical benefit. It doesn't say it's good to cool people, but you've demonstrated you can cool somebody to 33 degrees. And these are being used, and so there's not a great incentive for devices to run this trial, to fund this trial, so they're not going to fund this trial. There might even be a disincentive to fund this trial. The FDA wants this trial to run, and so we went to the NIH, and the FDA went on behalf of the design that we'd really like to see this trial run, which was sort of a unique experience in the whole interactions of getting this trial run. And eventually this trial was funded by the NIH.
Yeah, I think the FDA was even a little more excited, so to speak, about it, because really the labels for these devices are that they're to control temperature. So the use of them, you can set a different target, but really the idea was that they were to keep people at normal temperatures or potentially warm people up who have environmental hypothermia. So to some degree, every time I've given a presentation about ICECAP, I put in that disclosure, I will discuss off-label uses of these devices because the way that their label was. So the FDA felt that it was important from a regulatory science perspective to learn more about the safety of these devices when being used outside of their label. So that gave them additional enthusiasm for our design. And you're right, it was really unique, I think, to have FDA. I think FDA does a lot of great things. I think they can be great scientific partners. And I think in this case, this is a great example of that. Like in that they were interested in doing what's right for patients, but learning in an unbiased way through a clinical trial where all the adverse events are being adjudicated, the outcome assessors are blinded to the duration of this cooling device that they were subjected to and so forth. So a lot of real positives. I mean, it was a delight working with them on it. And, I was the sponsor of the IDE. So I've had great interactions with them. They're really, really thoughtful scientists there.
Yep. Okay. So let's summarize the design because, our listeners are going to tune into this and then they're going to tune into the results and we'll do a podcast of the results. So this is a design of 1,800 patients combined across rhythm types, where initially the allocation is 12, 24, and 48 hours, equal randomization. After 200 patients, an interim analysis is done. The Bayesian model is fit for both rhythm types. We do multiple imputation of patients with 30 days MRS status, projecting to their 90-day status. We have 90-day MRS as the primary endpoint, and we use a weighted scale of the MRS for analyzing that, not a dichotomization of that, so a weighted scale. At the interim analysis, updated randomizations are made to the different durations. That is done every 50 patients in the trial that the RAR is updated throughout the course of the trial. There's a possibility of opening up them on the right or the left. So the ones at the beginning, 12 to 48 are open and can be allocated to right away, and anything in between that by every 6 hours. And certain conditions could open up 6 hours. Of course, we talked about opening up 0, but that was not a possibility. So it could open up 6. We talked about that in the design stage. And then it could open up 60 or 72 on the other end if this appears to be a continual increasing duration response. There is no early success. There's no stopping because we've determined the right answer. There is futility if there's comes to be at least a 50% probability that 6 hours is the best thing to do. We'll stop a rhythm type. And we call it futility. It's largely that there's reasonable evidence that there isn't an increasing duration response curve. The two primary analyses are what is the optimal duration to cool that comes from the Bayesian model, and is there an increasing duration response? If there's an increasing duration response, if 12 is better than 6 and 18 is better than 12, it gives evidence without a 0 arm that cooling is beneficial. And the FDA understood the non-zero arm, and they understood this as a signal that cooling is beneficial to patients if there's an increasing relationship with length of cooling. Within that is part of the primary analysis in the trial, and the two rhythm types. Have I summarized the design appropriately?
Yeah, no, but we maybe take a brief little tangent into the weighted MRS, and I think others have probably seen this in the stroke world. For stroke, we developed this weighting scale for ICECAP a little earlier than the stroke one emerged. In the stroke one, they talked to clinicians and patients and families to develop a series of weights for the MRS states. And in adult ICECAP, we set these sort of based on what the clinicians thought, with the goal of accomplishing two things. Can we find people who more or less wake up, their MRS is sort of better than 4, and amongst those who wake up, can we distinguish amongst the people who have really excellent outcomes? I think when we commonly dichotomize, it's like you get full credit at a 0, full credit at a 1, full credit at a 2, and all of a sudden at a 3, you get no credit. It's the same as being dead. And that, in this disease, we felt was losing the possibility of showing important improvements, because someone with an MRS of 3, if they had a really severe stroke had the really severe cardiac arrest, at 3 months, that might be a very good outcome. And they actually may have a potential for future trajectory. And we're doing a study called post-ICECAP that we designed to actually live after ICECAP. But initially, it was following patients after their 3-month follow-up. But now it's following people at 3, 6, 9, and 12 months to look at that trajectory of recovery over time. And there are certainly patients for whom an MRS of 3 is a win in terms of their severity of injury. So we did design this weighted scale. It's very similar to the utility weighted scale that was used in Dawn and Diffuse and other stroke trials. It's subtly different, but it's the concept is the same, even though we arrived at it for a scientific reason, as opposed to inducing it from sort of clinician and patient preferences.
Just for disclosure of what it is, the MRS of 0, which is the best outcome, you get 10 points. A 1, you get 9 points. A 2, you get 8 points. A 3, you get 6 points. So the 2 to 3 difference was considered greater. And then below 3 for 4, 5, and 6, you get 0 points. Is the scale used, the weighting of that used in the trial. Okay, and we should highlight that MUSC and Sharon Yates ran this trial. They're the Data Coordinating Center, did a tremendous job on this in the trial. So complex, many interim analyses done during the trial, and they did a fantastic job running the trial. But we can't.
And one thing, like sometimes people are like, "Oh gosh, turning around an interim analysis to change a randomization vector in we do a data freeze," and they would turn it around in a day. and a few hours really. And it was they know it was coming, but it's also a protocol choice we made to say we are going to do this every 50 participants. We did also design a pediatric trial that has many features that are similar to adult ICECAP, but some that are different. And one of them is that because there was more equipoise in that trial, it does have a no cooling group. It has a 0-hour duration. Goes all the way out to 96 because of that data from neonates where 72 to 96 work well in them. But one thing is we did say that the interim analysis would be approximately every 10 weeks to just make it a little bit more predictable and nice. But Dr. Yates and the team at MUSC, they were phenomenal, and we were always keeping our eye on that. And but it would change. As an emergency physician and somebody who works in the ICU, and I take stroke call, I'm like, oh, I got to do something in the middle of the night on a Tuesday. I'm used to that. Generally, and again, this is not a slight on academic biostatisticians. That's not typically part of their workflow. But they got everything going so well, and it was just a delight.
Yep. Okay, we need to stop now because we'd start telling results. So look for ICECAP results coming when we do another interim analysis, which we love to do here. So thank you, Will, and look to see you very shortly. And thanks, everybody, and thanks for joining us. Until next time, we are here in the interim.